Welcome to medical school. I see you're all excited. I'm sure it will last. Now we're going to talk about, can you hear me all well? Okay. So clinical reasoning is extremely important in the day-to-day practice of any clinician. Your lifelong career, clinical reasoning is extremely important, and you apply it every day. And actually now it's clinical reasoning. Prior to coming into this room, you were all just using reasoning, right? And now your med school is going to become clinical reasoning. So for the next 50 minutes or so, I want us to talk about concepts. Don't get bogged down with details. I just want you to see the concepts and the concepts and the philosophy behind clinical reasoning, if you like. You probably have different backgrounds. Some of you have had some medical experience, shadowing, etc. So some terms may have meaning for you or not, but it doesn't matter. Don't get bogged down with the details. It's all about the concepts. So some experts have tried to define clinical reasoning, starting from probably the 60s and 50s. So one group referred to clinical reasoning as the cognitive process necessary to evaluate and manage a patient's medical condition. It involves knowledge, intuition. As we all know, intuition just comes to you, usually developed by experience, critical thinking, and constant reflection on the above process that I just mentioned. Others would describe clinical reasoning as the sum of the thinking and decision-making process associated with clinical practice, enabling physicians or clinicians to take the best judged action in a specific patient context. So two different variations of the definition of clinical reasoning. Now, essential to, if you want to grow, develop, and get very good at clinical reasoning, metacognition is very important in the whole process, okay? Hands up if you are aware that you are breathing right now. Okay, some people have forgotten, but you're still breathing, that's good. Hands up if you are aware that you think. Now, a different question for another lecture is, who or what is that awareness that is aware that you think? Is it the same or separate from your thinking mind? Okay. A different lecture. Maybe more at the bar or something, you know? Okay, so hands up if you're aware that you do think, right? Okay. Hands up if you think about how you think. Okay. Hands up if you think about how you think while you're thinking. Okay, so this is a natural, yes, we're all aware that we think. We usually think about how we think as a reflective process. You know, what did I do in the morning? What happened when I had a disagreement with this person? But not many of us think about how we think while we think. So my definition of metacognition is thinking about how you think while you think, all within the limitations of your thinking mind, witnessed by that awareness, okay? So that's metacognition, basically thinking about how you think while you think, so that you're constantly improving on your clinical reasoning or reasoning as a whole. So broad strokes, steps involved in clinical reasoning. So first thing is, we should understand, are there processes or is there a process that is a common denominator for all humans in terms of reasoning and all clinicians? Is there a common tool that we all use? If there is, then it's good to get to know it. And then as you understand that there are fixed systems, perhaps, you should recognize your own process of clinical reasoning in real time. So there are processes that everyone uses. I'm using this process right now, okay? Now, if there are processes that people use and common denominators, then almost invariably there are bound to be predictable pitfalls in reasoning, right? So understand the process, recognize your own reasoning, be cognizant of the fact that there will be pitfalls, because we're all human, and you will all fall into pitfalls. And having understood that, apply real-time strategies while we're still thinking about how we think while we think, to avoid pitfalls in clinical reasoning. It all sounds very abstract, but believe me, in a year, 2 years, you'll be doing, all of this will be happening at the spinal level seamlessly because you develop those pathways. And then, as a student, you want to be evaluated by your teacher. All you need to do is make all that thinking visible to your teacher. And when you're teaching your juniors, all you need to do is make that thinking visible to your learners. Okay? And what I find personally, once you personalize anything for yourself, if you do get dementia or you lose your memory, it's probably one of the last things you'll forget. Once you personalize something, an approach, it becomes yours, and it's always there at your fingertips. Okay? So we're going to kind of go through the steps involved. But now let's start a little exercise. Okay? So put yourself, all of you individually or collectively went hiking last weekend and scraped your right knee. Your skin around both knees is red and painful, and the red area is spreading. You have a fever and chills. What is the diagnosis? Day 3 of medical school. Just shout out, put your hands up if you want. Yes, sir. Infection. Okay, an infection. Any other ideas? Cellulitis. Okay, big word. Who said cellulitis? Hands up if you don't mind. Okay. So you have have you done anything medical? Yeah. Okay, cellulitis. Okay. Probably arthritis. Arthritis. Okay. So I want all of you to hold on to your diagnosis. You don't have to share it, but hold on to it in your head, okay? Now, the guy that said cellulitis at the back, right? Okay. The person sitting next to him, the lady sitting next to him, how did he do that? Did you feel him thinking? Did you feel him moving any machines in his head? No? Okay. So what's your name, sir? Lord Cellulitis. Jordan? Jordan, okay. Jordan, how did you do that? First of all, how long did it take you to come up with cellulitis? I know it took you a while to put your hands up, but it probably came to you within 5 seconds, or? Okay. Okay.
I'm not sure what was your question.
How did you do that?
Something that's very common in that setting.
Okay, but how exactly did you do that?
Somebody adding it, like.
Okay. Because you had to have a mental process to do that, right? So it's sounding to me that it kind of, this is like an example of intuition. Without active thinking, it comes to you, right? Based on what's available to you, what you have seen, etc., etc. And probably all of you have done the same thing. The gentleman who said an infection probably scraped your knee and your elbows as a kid, and you always got the spirits or the bandage, etc. So that is clinical reasoning. But as you can all see, that happened in a flash. Okay? Hold on to your diagnosis. But if we were trying to articulate what Jordan did, we could say, he synthesized the information and the data at the bottom of the screen. Then he created a problem representation to himself. So he synthesized the data, projected the problem to himself, and looked for any illness script in his database. Okay? Maybe he's running an Intel 10 or an Intel 1. We yet to know. But then he looked at the illness script in his database, and via 2 mechanisms that are usually available, one is intuitive and one is analytic. Sometimes they interact, and he came up with a diagnosis. And I would venture to say that in this case, Jordan, it happened so fast that it can only mean that Jordan went through an intuitive process without actively reasoning or trying to figure things out. Now, next exercise, Jordan, you stay out of this one. Next exercise is, I'll leave that on the board. So now if I say, okay, 3rd day in medical school, a 55-year-old homeless man presents with 5 weeks of cough, hemoptysis, weight loss, fevers, night sweats, constitutional symptoms. His x-ray shows bilateral cavity lesions with thick walls. His quantiferon test is positive. His HIV is negative. Oh, you're the new Jordan, are you? Okay, so for some reason, what's your name, sir? Johnny. Johnny? Jordan and Johnny. So for some reason, Johnny is applying an intuitive process, okay? But my bet is that most of you, if you had to analyze this, would probably Google it, MD Live it, but you will go through an analytical process. Some of you may be, what is hemoptysis? What does a quantiferum mean? What does it mean when you have night sweats and you have cavitary lesions, etc.? That would be an analytic approach, okay? So, but still, at different stages, what may be analytical to one person may be intuitive to another person, and it continues for the rest of your careers, to all of us, okay? So, based on the two examples preceding, clinical reasoning is a dual process theory. There are two cognitive systems involved in clinical reasoning, involved in reasoning in general, okay? Different names. I choose the intuitive process and an analytic process. So as we've seen with Jordan and Johnny, the intuitive process is a reflex system, it's experiential. He's had some experience in infections. Have you seen tuberculosis or?
I usually test positive. I live in Mexico.
Okay, okay. So by testing, so it's an experience you've had that that's inductive. And then Gestalt is just that gut feeling. And then the intuitive process involves a lot of heuristics. Has anybody heard about heuristics, the concepts of heuristics? Okay, we'll touch a little bit on heuristics. Big part in intuitive medicine. And as you can see with Johnny and Jordan, none of them broke a sweat. Very low effort. Cellulitis on TB. Low effort. But I bet you they have a very high emotional attachment to what they just said. Right? And that's the intuitive thing. Low effort, reflective, but you hold on to it. Very intuitively, right? Okay. And that's why when you have a jury of your peers, say you're in a court system, you really don't want people going intuitive, right? You want them to be analytic. They should forget about what they care about you or how you look or whatever. You want them to just deal with the facts. And that's what the analytic system does. It's deliberate, it's rational. You create a hypothesis. It's critical, logical thought. It's normative reasoning. It's very high effort, but very low attachment. You put in a lot of effort, but you're not emotionally attached to it. And what happens as a practitioner is that you develop both systems and they feed into each other. The more you analyze and figure something out, the next time you can run it down your intuitive pathway. Okay? Now let's talk a little bit about heuristics. Heuristics form a big part of the intuitive pathway, and a lot of practice in the clinical practice is based on heuristics. Now, heuristics are simply shortcuts in clinical reasoning. Shortcuts in reasoning. For instance, if you've ever said, oh, as a rule of thumb, that's a heuristic. On a negative style, on negative angle perspective, stereotyping, profiling, they're all examples of heuristics. If for any reason you think that the elderly grandma-looking lady is more trustworthy than the guy covered in tattoos, that's heuristics because you have no basis of knowing anything. That's just a shortcut in your reasoning based on your experience and your priming. So it's intuitive judgment calls based on certain aspects of a complex problem. It's influenced by prior experience. And the good thing about heuristics is that it's typically correct. The bad thing about heuristics is that it's sometimes wrong, right? Overall, it prevents extensive deliberation on each case, thus preventing excessive testing. I mean, if we had to say, is this cellulitis? If we had to biopsy everybody's skin that had cellulitis, put it under a microscope, try and grow some stuff just to prove it's cellulitis, that would be labor intensive and not cost effective. And if we do it 9 out of 10 times empirically and heuristically, that's cost effective for the whole population. So it prevents extensive deliberation on each case, and it produces desired results with a minimum of delay, cost, and anxiety. Okay? So clinical reasoning, you have the intuitive system. If a patient presents with clinical features A, B, C, D, and you've recognized ABD before, and ABD came with F, the odds are you're more likely to form a diagnosis that has as much as possible of what you've seen before fit in the pattern. For the analytic system, you're going to have to go try and match each thing and see how each thing interplays with the other. So it's very mentally laboring. In an ideal world, you'd start with presentation, case representations. You grow hypotheses, you test them out, you find out you're right. You'll see many cases of patients with, say, cystitis. Eventually, you recognize cystitis in your sleep, and one feeds into each other. That's in an ideal world. But we don't live in an ideal world. So in the real world, what happens is that it gets very messy. There's a lot of emotional override, a lot of egos get in the way, so many things, some system things, some technology gets in the way, past experiences, bad experiences, medical legal experiences. It just messes up the whole system and ends up producing delayed or missed diagnosis. Okay? And these are called due to pitfalls in clinical reasoning. We make mistakes when we encounter complex problems. And as you practice in your career, you think that, oh, that was so simple. How could anybody get that wrong? But you see again and again, all levels of specialists involved in care of patients that just fail to see the obvious. That said, because everyday situations are often complex enough to elicit mistakes. And after a while, you realize that mistakes are not random. So, what are these pitfalls in clinical reasoning? There's a whole field out there. I think there are about 110 defined biased judgments, fallacies of heuristics, or impaired cognitive dispositions to respond, otherwise cognitive, aka cognitive errors. And a few of them like aggregate bias, anchoring, gambler's fallacy. You know, who knows what a gambler's fallacy is? Oh, Vegas crew. What is the gambler's fallacy? Can you share with us?
If you're winning, you're going to keep winning.
Exactly. So if you think you throw a dice and you get 10, you're going to keep getting 10. Okay? That is actually a little bit of the reverse of the gambler's fallacy. That is kind of a post-odds. You think it's still going to keep happening. The true gambler, so you're not a true gambler. The true gambler thinks that if it was heads up 10 times, the 11th time, it should be tails up, right? The coin should be fair, right? But the coin has no memory. But yes, you attribute all of this that, okay, it's about time for, but each toss of the coin is the same odds, etc. And there's a psych out error where many patients their comorbidities get ignored because everyone focuses on the fact, rightfully or wrongfully, or due to implicit bias, that they have psychiatric conditions and neglect the fact that they may have something else going on. The yin-yang out effect is when you've done so many tests, you're like, oh, like, this patient is back again for the 17th time. We're not doing anything. We've done everything. There's nothing else to be done, etc. So I would like to share with you just 10 of the most common, just concept again, not details. So remember your diagnosis for the hiker? Hands up if you had your own diagnosis, because you're all the hikers. Everybody has diagnosis in their head? Excellent. So let's walk through the hiker's diagnosis and apply. You see that you applied a lot of heuristics. So each heuristic and its pitfall. The availability heuristic, as Jordan said, is the ease of recalling past cases, okay? Because Jordan has seen an infection or cellulitis before, the next red knee that comes to him is going to be an infection or cellulitis. But it is subject to base rate neglect. And in this case, Jordan, I would just challenge you, probably 11 out of 10 cases with a scraped knee and the knee is red and there's a fever would be cellulitis, okay? And that's probably what you've seen before. Now, how many cases of one knee scraped will present with two knees red? You see that? So that's an inconsistency, and that's already you've fallen into an availability heuristic. I scrape my left knee, both knees are red, right? And there's a gap between your knees, right? So there's no way you could have jumped from your left knee across the space to your right knee, okay? But this is what happens to clinicians. This is just a very simple example, okay? So if you actually acknowledge base rates, the likelihood of getting cellulitis bilaterally, two knees at the same time, is minuscule. Okay? Okay. So anchoring. Now, Jordan probably, again, low effort, high emotion, okay? Jordan probably said to himself, you know, this is cellulitis, I'm relying on cellulitis, this is my gut feeling, and everyone thinks they have the most intelligent gut in the world, right? My gut feeling is right, this is cellulitis. And subconsciously, without doing it, Jordan just ignored inconsistencies in the data. Both knees are red, okay? And then Jordan might generate a diagnostic momentum. And what would Jordan do? Maybe Jordan is from out of town. On the weekend, he'll pick up the phone and he'll call Dr. Mom. Hey, Jordan, how's it going? Yeah, Chicago is great. You know, I went hiking with some friends. I scraped my knee. Now my knees are red. I have a fever. And he's going to frame it that way to his mom. And his mom that's looked after him since he was a baby is going to say, oh, you have an infection, right? And that's because you framed it to your mom that way. And you're not going to frame it to your mom. You know, I hit one knee, but both knees are red. So your mom will continue. You've generated diagnostic momentum and you've biased your mom. Now, blind obedience. If your mom says, go to Walgreens, buy a wrap, a hot compress, a cold compress, put two of this there, 2 grams of that there. And if you're terrorized or very loyal to your mom, that's undue deference to your mom's authority. And then you guys close, and that's what you have, okay? So those are heuristics, and then premature closure is when you just narrow down. And in doing that, what happens that if you have fall in the availability pitfall, and you go down, you anchor, and you close prematurely, you're just going to see things that you want to confirm your idea. So that's going to be called confirmation bias. You want to confirm what is in your mind. Same thing, representative bias, right? So you're more inclined to estimate the probability more so on how well it fits the typical characteristics of a category. In this case, the category was cellulitis. It's red, it's hot, it's painful, there's a fever, right? And neglecting the base rate and the consistency, which is it's both knees. So some of them overlap. So confirmation bias, you focus on data that supports what you want. Perhaps you go to the store and you get an antibiotic cream and you put it on one knee and you take Motrin for the pain and it was arthritis and both knees get better. You're going to see, wow, that cream works. Then when your roommate has a equally severe arthritis or something, then you're going to recommend the same. Then an illusory correlation is thinking that the fact that both knees are red had anything to do with hiking. It may do, it may not. But you just made that assumption that every disease has to start at some point, right? Maybe this is Lyme disease from when you went hiking 4 weeks ago. It just so happened you went hiking again. Maybe you're a hiker, okay? And then the hassle bias, this is usually like 2 a.m., that patient that speaks only one dialect, there's no interpreter around, and the tendency to take the easy way out. When you're idealistic, you think this will never happen to me. When you're tired, burnt out, and fatigued, the easy way out is the best way out. Honestly, okay? So, how do we correct these pitfalls? I've kind of said everything. So, verify with legitimate statistics. How often is it bilateral? Always explain inconsistencies. Examine the case from an alternate perspective. I scraped my knee, but both knees are red. Last 2 weeks ago, I remember I had a sore throat and a fever. Maybe there's something else going on. And then blind obedience, you could just say, Mom, can you pass the phone to Dad? I would like the second opinion, if you don't mind. And your dad will say, what did your mom say? Yeah, she's right. And we're all human. When you're tired, and instead of closing down, just take a break and return to the case when you're refreshed, okay? And then overconfidence, be aware of the limitations of your knowledge. Physicians at every level are so often wrong. In fact, there's some data that say we are wrong much more than we are right, okay? And if you follow patients and if you work at the same institution for a long time, you would have discharged that patient in January, pretty certain of your diagnosis. Guy comes back in July, you realize what on earth was I thinking, And question correlations objectively, and for the Hassel bias, it's the 30th anniversary of Nike's advert slogan, right? Just do it. Now, let's switch gears. Again, just concepts of clinical reasoning. So I just, by show of hands, if you're superstitious, you don't need to get involved. If anybody had a 1 to 2% chance of having pancreatic cancer in this room, would you want to be tested? Hands up if you'd want to be tested. Wow. 1%? I see you definitely, life is to be valued. Agreed. Okay. How many of you would consider testing for pancreatic cancer if you had a 50% chance? So, subconsciously, you're all placing different values on your life. Okay? Okay? 1%, no chances taken, right? Pancreatic cancer.
And 1% now.
Yeah, no, there's no right or wrong answer. I'm just, kind of exploring the room. So, if you have a 1% chance of having pancreatic cancer, hands up if you do not want to be tested. Okay, several people do not want to be tested. Okay, can I use you?
Sure.
You're not superstitious. What's your name?
Fadi.
Fadi. So 1% chance of pancreatic cancer, you don't want to be tested, right? That's okay. There's no right or wrong answer. Okay. You want to go out in a blaze of glory? No, you don't need to know. So, Fadi, right? Fadi, let's say your 4th year of medical school, clinical rotation. You're learning some procedures, you're doing an ABG, very exciting, and you're doing on this patient, and this patient happens to have HIV, full-blown AIDS, and you accidentally stick yourself with the needle after sticking the patient.
I'll tell you what's going to happen. I'm going to freak out, okay? That's happening.
Okay, so you're going to freak out.
Yeah.
But are you going to want to be tested or treated?
Well, I'm going to go to the doctor and they're going to say there's a very low likelihood because it's a needle, right? But I'm still going to want to be tested.
You're going to want to be tested then? 4 weeks? 3 months? 6 months? And probably 12 months to be sure, right?
Yeah.
But what is the percentage risk?
Very low.
It's less than 1%.
Yeah.
So in as much as you didn't care for the pancreatic cancer, you can't walk away from the needle stick. I mean, your doctor probably won't let you walk away. But what it shows is that even for the same person, different conditions have different thresholds, right? And then there's emotional attachment and then there's an emotional component, Pancreatic cancer, even if you have a 5%, it's not there, you can't see it, right? But if you stick your needle, oh my God, you're going to, what you said is right, you're going to freak out. Yeah. You're going to question your whole role as a doctor. You may take 6 weeks off school. I mean, things like that have happened, okay? Okay. So what we're trying to establish is actually what physicians consider the testing threshold, okay? For purposes of this discussion, let's use 5%. Let's use 5% as testing threshold. Anything below 5%, again, it varies with each individual and each condition. Now, if you went to the hospital with tummy ache, and I told you, I think you have appendicitis, I have a 50% certainty that you have appendicitis, would you go with me to the OR? Hell yeah. Your value on your life is paradoxical, Right? What happens in the OR? Anesthesia, cut open, bleeding, infection, and I only had a 50% certainty. And you go with me to the OR?
What are the chances of the infection in the OR? Then you can compare that to the chances of you having a ruptured appendicitis or electrolysis.
What about the 50% chance that you have nothing?
I walked away with infection.
Oh, at least you did it, yeah? You've done your top duty, get a tattoo, went to OR for nothing. Okay, if you told me that you have a 50% chance that I have appendicitis, I can operate now, I would say, can you do anything else to be a bit more certain before we go to the OR? And I said, okay, if you want to, I can do a CT scan, I'll be 95% certain. Or we can go straight to the OR. Which would you prefer?
Let's go to the OR.
Okay, let's go to the OR. Okay. CT scan. So that's your treatment threshold. Okay? Another way to think of this, same thing, is just to consider your pre-test probability of disease. These are concepts that clinicians use, and your post-test probability of disease. Now, all we do is apply tests. Tests have sensitivities, specificities, predictive values, and we try and shift things to below treatment threshold where we can reassure the patient, or as close to treatment threshold where we're comfortable exposing the patient to treatment that may have side effects. Okay? So, for every test you're going to do, biopsies, anything you do, almost every test has known sensitivity and specificities compared to gold standards. Positive and negative predictive values, you've probably done all some of this in statistics, depends on prevalence of disease. What is most useful for the individual patient, independent of the prevalence of the disease, is actually the likelihood ratio, because it can be applied to each individual patient and is the most effective tool at shifting your pretest probability. And I'll show you how. And don't get into the specifics, just the concepts, okay? Likelihood ratios based on sensitivity and specificity can be positive or negative. So a likelihood ratio of 1 has 0 effect on your post-test probability, okay? For instance, the CT, if I said the CT scan has a likelihood ratio based on its sensitivity and specificity of 10, I can tell you that after your CT scan comes back positive, I'm 95% certain you have, okay? If your CT scan has a likelihood of 0.1 negative, after the test, I'll be like, you know what? No need to go to the OR. You only have a 5% chance, unless you're hell-bent on going to the OR, okay? And then don't sue me after the OR. So this is how you move your pretest probability for. So remember the concept of likelihood ratios. Okay. The most limiting aspect in your life as a clinician is going to be how do you actually determine where you start from? How do you actually determine what is the true pretest probability of what you're considering? And how do you do that? You're going to have a session on history and physical taking. From the history you take, from the physical exam, from known prevalence of disease, when it is known, and from prediction models. That helps generate your pretest probability. So all the talking and the hands-on and examining help, you're really just trying to get the pretest probability. And then all the testing, the blood, the urine, the MRI, the CAT scans, you're just trying to shift that pretest probability to treatment levels or to below testing threshold and reassure the patient. Okay? We're almost done. So let's start with this case history. Okay? Concepts, no specifics. A 56-year-old woman, history of hypertension, presents to ED with 2 weeks of shortness of breath. She gets short of breath while walking, associated with chest tightness but no pain. She has noticed a cough productive of whitish sputum but has not had any fevers. Though 3 weeks ago she had a cold after a long flight from China. No history of tobacco. Her hubby has noticed that she wakes up short of breath at night and sits up to open the windows. Her legs are also swollen, but the right is more swollen than the left. Any thoughts? Just throw anything out there. Cellulitis? Okay. You are going to the OR after this. Right after the session.
PE or DVT?
PE or DVT because of the long flight from China, the swollen leg. Yes, ma'am? PE, DVT, anybody else? Cellulitis to the OR?
Heart failure?
Heart failure? You see, you guys are all physicians already. Heart failure, PE, anybody else? Okay, excellent. So, residents would probably come up with heart failure, pulmonary embolism, pneumonia, other things, okay? Cellulitis may get in there. Okay. So this is a physical exam. Don't get into the details. It just shows red leg, the right leg is more swollen than the left, but just 1 centimeter. The heart sounds are normal, the lungs sound clear, the blood count is normal. So blood chemistry is normal, chest x-ray shows no pneumonia. So you can already exclude some things, okay? But some things you cannot. So from that initial list, you can exclude pneumonia, etc. But you're still left with heart failure and pulmonary embolism, like you guys rightfully said. But nothing stops you from having both, right? Okay. So how do we apply what we've learned now? What do we need to do to generate a pre-test probability for heart failure and for pulmonary embolism? See which has a higher pretest probability. And how could we possibly do that? Like we've learned, we can go to our history exam. In this case, the exam didn't show anything that can really help you differentiate. So then we can now rely on known prevalence of disease and prediction models if they're out there. So I can ask myself, across the world, of all the people that go to an emergency room complaining of shortness of breath, which is my patient cohort, just anybody that goes to the ED, what do they end up having? Then you go to the literature, and then you find that it's been studied, for instance. So this study looked at 1,600 patients, 5 countries all over the world. At the end of the day, pretty much 50% had heart failure, approximately. So if somebody just walks in short of breath to your ER, if you just say heart failure, you're 50% there. But don't forget, 50% is not satisfactory. It's not close enough to treatment, and it's not reassuring enough. Not many people will follow you to the OR at 50%. Okay. So we know heart failure is 50%. Now what about PE, our 2 top differentials? You'll come to learn that there are prediction models that have been validated. Wells is for PE, where you look at clinical points and history. So our patient only had a heart rate above 100, which is a score of 1.5. And then you go to the literature that looked at 31,000 patients that ended up having a PE. And they find that, so our patient is intermediate. Our patient's pre-test probability is really between 6 and 28%, based on what we know, as best as the knowledge can tell us. So if you go back to your line, this is your patient. PE 10 to 25%, heart failure of almost 50%. But as a clinician, you cannot leave your patient in the middle zone. You have to move them. So then you apply all you know. We go back to the likelihood ratios. Then it just turns out there is one test. It doesn't matter, you learn about it later. There's a blood test called the D-dimer. Okay? It turns out that this blood test is very sensitive, 95%, and is 40% specific. And if this blood test has an LR negative of 0.1, this is where likelihood ratios are more important. You can apply it to any patient independent of prevalence. So this is called a Fagan nomogram. So you started out with 20%, you draw a line that crosses your 0.1, and you're left with 2% for PE. So guess what? You can stop. You can reassure the patient and move on to heart failure, right? This saves you even, it's such a good blood test that it saves you even doing a CAT scan to look for PE. Now, the other side to this is that if the test was positive, the likelihood ratio is pretty weak, 1.54. It would only shift you to 35%. So this is how you play with the positivity or negativity of a test result and apply it to your patient. Always remember likelihood ratios. So it turns out there's another blood test for diagnosis of heart failure called the BNP, with sensitivity of 90 and specificity of 76%. We started with a pre-test probability of 50%. It turns out the BNP above 4 has a positive likelihood ratio of 4. It takes you to 80%, pretty close to treatment. On the other hand, if it was negative with a likelihood ratio of 0.1, it would take you down to 9%. Okay? So at the end of the day, to summarize the case, the D-dimer made a PE 2%. The BNP made heart failure go to 80%, and an echocardiogram was done which showed there was some dysfunction with the heart, okay? So the symptoms were caused by heart failure. This is almost a scientific, mathematical approach to diagnosis, but it also happens intuitively, eventually. Now, so we put PE there, and we took heart failure there. Then we can treat for heart failure. But this cycle of reasoning never stops. Why? Because you're going to ask yourself, why does the patient have heart failure? Right? Then you're going to start again. What is the pretest probability of all the people in the Western world that have heart failure? What causes it? And you'll find that coronary artery disease is the most common. So in this case, coronary artery disease was considered. It was excluded with the coronary angiogram. There was no blockage. Then you're going to ask yourself, the patient had a cold 3 weeks ago. Could this be a viral inflammation of the heart? Then you're going to try and determine your pre-test probability. What test can you use to shift your post-test probability? Can you do a cardiac MRI that shows inflammation? This is the essence of what we all do in clinical practice. Surgeons do it with their hands. Radiologists do it by looking at the films. Dermatologists do it by looking at the skin and drive BMWs while they do it, you know. So the thing is, the cycle of reasoning never stops. It continues again and again and again, okay? So we've talked about the process. We've talked about recognizing your own process, pitfalls, real-time strategies. And I'm just going to leave you with an example of what I mean by personalize your approach. This is my personalized approach to cases and to discussing cases with residents. And I made an acronym. I call it a Diva Prof. Okay? I'm not a Diva Prof, but I thought it was a catchy phrase. So A is I have to ask myself mentally, cross-check this in real time. Am I really giving an appropriate pretest probability? What is the most effective discriminating factor to narrow down the field? Am I internally consistent? Are my assumptions validated? Am I anticipating a response to both tests, positive and negative? Because a test is not only going to go the way you want it. So am I constantly aware of how to use LR positive or negative? Am I probing to disprove my hypothesis, reframe my framing, reconcile my inconsistencies, and realize that after all of that, I'm often wrong, but it gives me a chance to figure out why, okay? And each thing counteracts the yellow lines are the pitfalls that each strategy counteracts, okay? These slides are going to be up, so you have access to them, each thing that it counteracts, okay? And then when you realize you're often wrong, it brings the necessary humility by medicine, and it inspires lifelong learning, okay? Medicine is a science of uncertainty and an art of probability. I wish you good luck, and I hope you enjoy the journey. Thank you. Any questions? Yes.
About the probability information, where do most physicians find that? Is it a journal research? If you have, a few diagnoses you're toying with, how do you really get to an accurate?
Yes. So, like I said earlier on, that is actually I think the most rate-limiting step in the practice of medicine. You get there by experience. So you get there by heuristics, by intuition. You get there by data. You get there by this particular problem your patient presents. Like if I have a patient who had a cough and I may have to go and seek the literature myself and say, prevalence, for instance, of oriental cholangitis in the Western world, if I think I have a rare case like that. So as you grow, as the problems come, you use the problems as mesh words to find out exactly what your pretest probability is. And many times you cannot. You have to just do your best educated guess. But just to make sure that you're not emotionally biased, right? I'll give you an example, very quick example, real-time example. In the Chicagoland area, there are approximately 100 cases of tuberculosis every year, okay? Of the 100 cases, 1 to 5% of them have TB meningitis. So most of them are pulmonary TB. They don't have meningitis. The diagnosis of TB meningitis and empirical treatment for TB meningitis is done so often. For instance, I work at Cook County in my patient population because a lot of my patients are immigrants and come from developing world. But even inclusive of that population, only 5 in the whole of Chicagoland get that. So that is where we are starting. We think we're starting with our intuition and our experience-based pretest probability, but we're neglecting base rates. And many times we treat patients empirically, and then something goes wrong with the liver, etc. So there's no magic formula for it. It's the tension of being a clinician. Because once you have that will be so easy. Once you have that, the test part is easy. You can put in a computer, LR positive, LR negative, this is what we have. It's that coming up with the starting point that's very difficult. Yes, sir.
Of that list of heuristics that you listed, what would you say is the most common and most dangerous in medicine?
Okay, very good. I think anchoring and premature closure, they go hand in hand.
Anchoring and
Premature closure. It comes to you, low effort, high emotional. I mean, I have a phrase. I have 3 phrases. 1 is borrowed and 2 are mine, okay? EBM stands for evidence-based medicine. You all heard that, right? But there's a parallel world. There's a dark world of EBM that stands for emotional-based medicine, okay? Where your emotions mess up with your reasoning, actually. And the other one is anticipatory medicine. Any test you order, anticipate positive or negative. One of my residents at Cook County famously said, when his test came back positive, he said, "Oh my gosh, if I knew it was going to come back positive, I wouldn't have ordered it." This is a quote. He's going to be chief resident. I mean, he was so frustrated that he came back positive. But you need to anticipate on both sides. It's too late now. Oh my God, I wouldn't have done this. Okay, you did it. It's positive. You know. So I think and I do a lot of M&M morbidity reviews. I think anchoring and premature closure, and blind deference to authority. The specialist said this. You know, the cardiologist said this, and everybody shuts down. You know, they're as vulnerable as anybody is. They're only human. Yeah. Yes, sir.
So with the probability line, there was on the close to the 100% side, there was a treatment threshold, right?
Yes.
And then the post-test probability got closer up. What is the range that you determine to say, you know, like, this is when I will treat? Because with the heart failure, it went up to
80%.
80%, and then the treatment threshold was around 95.
So these are all arbitrary values, right? Some people do 15 and 85. Some people do 20 and 80. It all depends on the condition and the individual, right? If it's 80%, it's most people that are treating heart failure are at about there, 80%, right? And especially if you do it the right way and the flow goes as it should go, you will be left with no other reasonable contesting diagnosis, right? Yeah, because PE was out, pneumonia, everything was out, and all you're left with is heart failure, which is just a syndrome. You start treating the heart failure, and then you continue. Why does the patient have the heart failure? And then you keep going, right? Because heart failure really is just what it's presenting as. It's what is causing is the next thing. So these are arbitrary values. I just don't get stuck on the numbers or the details. I just want you to familiarize yourself with how the thinking, the science, the concepts behind the thinking, because all you're going to do all your life is just this, in one variation or the other, seriously. And you're going to see that you can never master this.
One more question?
Mm-hmm.
How does this process change when you have to make immediate decisions?
It does not. It does not change. The only thing is that you fast-track most of the time into the intuitive system, right? And it depends on what you mean by immediate. If I've been managing a patient for 4 days on the ward and he suddenly crashes, I'm making my immediate judgment, but it's all based on all the data I have from the last 4 days, right? If I just walk into Oscar supermarket and someone's on the floor, all I have to do is just act, resuscitate, etc., etc. So it's constantly, from the minute you start working on a patient, you're building up stuff, you're remembering everything, and then by day 4, I'm like, oh my God, that's why the ferritin was so high on the first day. And then the patient crashes, you have to go to life-sustaining, but then you're thinking, okay, when, like the MICU might come, and then maybe what's going on, like, oh, you know, he came with anemia, his skin is very dark today, he's been flushed, I think he's bleeding, you know. You may be right, you may be wrong. I think he's bleeding, I think he needs an EGD or colonoscopy. And it may well be, sometimes it's happened to us, he's bleeding, but he's bleeding intraperitoneal, he's not bleeding externally, you know. So, you know, you just have to, in an emergency situation, most times you go with your intuition. When you buy an airline ticket, is there a doctor on the plane? No. Is there a med student? No. Okay, all the best. Okay, good luck.
Thank you, everyone, for your attention. I will see you guys later this morning, this afternoon, and we have the next 4 years to continue having these discussions. So thank you.